Welcome to the Mind Body Temple podcast, your healing space with Dr. Rod. I have the honor and pleasure to have Dr. Larissa Mcketton again here. She is a neuroscientist and brain specialist that will explain some nuances about the neuroscience to us today. Larissa, thanks again for giving us the opportunity. I wanted to talk to you today about many of the medical conditions that are hard to diagnose. You know, as physicians, we are used to putting different conditions into different boxes and put a name on them. And then there are times that the tests that we do and the presentations that we see, they don't match with the history that we get from the patients. Nevertheless, their conditions are real, and a lot of patients are suffering from them. In my practice that I deal with chronic pain patients, I see many times that there are patients that are suffering from different conditions that is more widespread or more versatile than different labels that we have. And even if you put a label on a diagnosis for that condition, it usually does not explain the whole condition very well. So I just wanted to see if we can have a little bit of discussion about this.
No, yeah, thank you for having me on the podcast, Dr. Rod. I thought it would be a great opportunity to talk about these different conditions of the mind that cannot be medically explained, and why that is, and what are the different types of conditions too. So we can talk a little bit about the differences between each one. But it is believed that up to 1 in 3 primary care visits are due to unexplained symptoms. That's quite a large number of patients that you're seeing, or clinicians or healthcare practitioners see. 1 in 3 based on unexplained medical symptoms. So then we can break it down to different types of conditions or disorders. So the primary one I wanted to talk about is known as somatic symptom and related disorders. Okay. And these include a range of mental health conditions where individuals experience many physical symptoms. So it could be chronic pain, fatigue, itching, or just many different variety of symptoms, but there is no medical explanation for them. And this was previously known as somatoform disorder or somatization. And based on the Diagnostic and Statistical Manual of Mental Health Disorders, the 5th edition, DSM-5, we now refer to them as somatic symptom and related disorders. So that's the most recent.
It's good name. That they came up with that that name finally, because in the pain space we don't have a consensus of the name. They used to call it psychosomatic disorder, then became somatoform disorder. Then now we have different names in our area of practice. They call it neuroplastic pain. They call it psychophysiologic disorders. And it's not just pain, it's so many other disorders. And it's good to come to some sort of understanding on, regardless of what we call them, we need to understand why they come about, why they happen.
So if we go and just break down somatic symptom disorder, and I can talk about the other ones, they have different prevalence rates and different diagnosis criteria. So somatic symptom disorder, it involves these distressing physical symptoms that disrupt daily living. And there's a lot of excessive worrying, and there's this component, the psychiatric component of depression and anxiety that could also be related. And they have different prevalence rates. So just to define what the term prevalence means, it's a term to say how many prior cases or pre-existing cases and current cases there are to date of this condition in the population. So it's like a snapshot of how widespread this condition is. That's what prevalence is, whereas incidence just means how many new cases there are. So the prevalence of somatic symptom disorder is about 5% of the population.
Wow, that's amazing. 1 out of every 20.
That's a quite large number, and it affects women more disproportionately than men. So up to tenfold increase, so 10 to 1 is the ratio, where more women...
It's more common in women.
It's more common in women than in men. And so another category of or related disorder is known as illness anxiety disorder. It was previously referred to as hypochondriasis, and this is also different than somatic symptom disorder because in that it is characterized by someone having this preconceived notion that they're having this illness despite minimal symptoms. So for example, you can have a patient coming in, they're saying, I have, a headache, it must be a brain tumor or a brain cancer. So,
Right.
and the most important part with this this case is that it's the belief that they have it. And it might be more related to obsessive compulsive disorder, this ruminating thought that they have it. And the prevalence is a bit more rare. It's 0.5% of the population, and it affects men and women equally.
Equally, yeah.
So that is illness anxiety disorder. And another category is something known as conversion disorder. Now, conversion disorder is more similar to somatic symptom disorder in that it presents itself with these physical conditions that cannot be explained medically, but the origin is more neurological. So the symptoms are more of related to a neurological basis. They can involve paralysis or tremors. And again, it's more common in women than men. So 3 to 10 times more commonly diagnosed in women than men. And there are different treatments for them. So treatments for somatic symptom disorder and illness anxiety disorder, they typically have beneficial treatments and outcomes when they do cognitive behavior therapy, CBT, or if they're having anxiety and depression. So if they're put on an SSRI, serotonin reuptake inhibitor, or an antidepressant. So those are common treatment options for those conditions. Whereas conversion disorder, those patients typically don't respond well to CBT, but education about that condition and the nature of their
Source
condition.
of it,
Yeah.
Where is it coming from?
Where is it coming
and
from?
why it's presenting itself this way.
So that is more helpful with that disorder. So again, it presents itself slightly different, but there are these nuances with these conditions. But we can even talk further. So that sort of bucket was somatic symptom disorders. There's another category where you may see patients as well where they're presenting with these physical symptoms, but the origin, you might not know where the origin is coming from. So these conditions are known as functional disorders. So, for example, fibromyalgia is under functional disorders, and IBS, irritable bowel syndrome.
Yeah.
There might be others, but for example,
These are the common ones.
the common ones, but there might be others, but they're different than somatic symptom disorders. So they're categorized as functional disorders. So fibromyalgia, you might have had patients who had fibromyalgia.
Oh, see.
Yeah.
It's a very common condition.
Very common. It's characterized by chronic widespread pain, often fatigue. Often they also present themselves with having cognitive issues.
Yeah, brain fog, they call it. Yeah.
Brain fog. And sometimes these symptoms just come out spontaneously. There might be a trigger where they might have had a traumatic experience or a traumatic episode where it could have triggered these symptoms, but not all cases involve a trigger. But in the vast majority, they would probably have a trigger. And where the underlying problem of fibromyalgia, where it might come from, it could be thought more of something called as nociplastic pain or centrally sensitized pain. So that's a disorder of how the pain is being processed in the body. So they might be more hypersensitive to the stimuli, or how internally how the body is feeling. They might be more hypersensitive. So nociplastic pain, I know we talked about the different nomenclature.
Yeah, different names.
It's different than nociceptive pain. So nociceptive pain is pain related to like inflammation or injury.
It's usually the usual pain that we see because of trauma or degeneration. Yeah. Basically, nociception is perception of pain.
Yeah.
So then the nociception can turn into the plasticity, which is that whole pathway of the pain. When it goes to brain, it passes through so many gates. Yeah. And brain understands the pain and then orders, okay, I got the message, now you can stop. So there's an ascending pathway that takes the message to brain, and then from brain coming down, there's another pathway, descending pathway, that tells, okay, stop. So those gates start to close. What happens is that when all those gates open up, the pathway of pain becomes a highway of pain.
Yes.
So that's the plasticity component that happens. Like there is a change in neurophysiology of transmission of the pain. So the pathway that's supposed to stop the pain will be dysfunctional, and the pathway that's sending the signal of pain becomes hyperfunctional. That's why we call it chronic widespread neuropathic pain now. It's another one of these names that we use to explain the fibromyalgia. It's overactivity of nervous system on the pathway of the pain, and any touch, cold, any stimuli,
Can set them off, yeah.
can make the pain so much worse. And they are very sensitive to these conditions, and it's different from when there is actual nociception because of inflammation or degeneration
Yes.
that happens. It's a different, altered physiology. Although, as you said, if you put any tissue under microscope, you're not going to see any damage. It's a problem of the function, not a problem of the structure.
Exactly. And there's also, to make it even more complicated, there's neuropathic pain, which is nerve damage too. So
That's
there's
because that's secondary nerve damage, yeah.
So there's, so that's like fibromyalgia. And then another functional condition you might have had experience with, dealing with and patients presenting themselves is irritable bowel syndrome. So that's also very common.
That's very common, yeah.
And it's a gastrointestinal disorder, and even like how it manifests itself, it could be due to a disruption in the microbiome if someone takes antibiotics. And there's this link between the gut and the brain through the vagal nerve.
More and more people are talking about that. Can you talk a little bit more about that component of interrelation between our nerves? Although I know that we call it gut, but it's full of full of different nerves and nerve endings. So it's a continuation of our whole nervous system that ends up there. But yeah, describe it a little bit more.
Well, IBS, irritable bowel syndrome, I know there's different subtypes of it. Right. And so even there are differences between men and women. There's sex differences between them as well. So for example, IBS-C, the constipation subtype, that is more prevalent in women, and they're also they also have more symptoms of bloating and nausea. And the IBS-D, that type is more prevalent in men. So there are differences between men and women. And with the IBS type C, why it might be more prevalent in women is with fluctuations or estrogen and progesterone, they're known to relax smooth muscles of the GI tract, so that can slow the transit time of stool. So like there are differences between men and women, right, even within the subdomains of IBS. But how it manifests itself, there could be a psychological component to it, because the gut-brain axis are very, they're linked up.
They're linked, yeah.
And that feeling you're getting, I have butterflies in my stomach, or I'm nervous, or I have a gut feeling, right? So a lot of the times the symptoms can come from here and travel up. So it's this feedback loop that people are experiencing.
That's where the history of emotional trauma, childhood adverse experiences, or teenagers' difficulties, and even current events, stress, comes to play. In our practice, these numbers that you mentioned are staggering. In our practice also, something was 40% of patients are suffering from some sort of background of emotional issues that are presenting themselves as the current physiological dysfunctions. Some of them lead even to structural changes, and some of them lead into these type of syndromes that we cannot describe with the normal nociception explanation of the conditions. So there is interrelationship between the emotional trauma and the effect of it in the nervous system and how the perception happens, right?
Yeah, and if you think about all these conditions I talked about, what's one common aspect with all of them is anxiety, depression, stress. And I wanted to talk about a little bit of the difference between internalizing and externalizing disorders. So internalizing disorder, it's a term we use to describe like people who have high levels of like anxiety, depression, ruminating thoughts, and it's more prevalent in women. Whereas externalizing disorders like ADHD or opposition defiant disorder, ODD, or conduct disorder or antisocial personality disorder, they're more common in men. And so when you ask, well, why is it more common in women and men? It's just, so I was looking through the literature, and there might be neuroanatomical differences. So for example, studies showed that there are differences in a structure in the brain called the ventral medial prefrontal cortex between men and women. And this is why, for example, men are more likely to engage in this reward-directed approach behavior. Maybe it's more related to why they have higher rates of externalizing disorders. But why women experience more of these internalizing disorders, like stress, depression, anxiety, it's more prevalent in IBS, in somatic symptom disorder. When I talked about those numbers, the rates are like 10 to 1.
Yeah.
So why is that? And it's so interesting to ask yourself, is it more that women are more in tune with what's happening in their bodies, and they feel like these symptoms more, and they perceive them more, and so they're more likely to report that they have these conditions? Is it more due to hormonal fluctuations with like estrogen, progesterone during perimenopause or menopause, and looking at, or throughout their whole lifespan, where they're more likely to, where the hormonal fluctuations are related to these symptoms? So,
Or their stress
or
level
their
that
stress
they're
levels.
exposed to.
Yeah.
You know, we are living now in a society that people talk about equality of men and women, but this hasn't been the case all throughout the history. And even the situation, like one of the indications of progress of any society is the state of their women in that society. And if you look at the whole landscape of the world, of course, you see many places that they don't have such a very good standing in the society, and they're exposed to increased amount of stress and emotional problem. That's why if you look at many other conditions like autoimmune disorders among women are more than men, and you have so many different conditions that are more prevalent in women. And if you look at the source, there's always a stress factor there.
Well, if you look at dementia, I know we talked about at our previous discussion, 2 out of 3 diagnoses for dementia are women, 2 to 3, whereas 1 out of 3 are men. But Parkinson's disease is more prevalent in men. But dementia is interesting because there's also studies that looked at caregivers of those with dementia are at a higher risk of also developing dementia themselves, and a lot of caregivers often are women in these roles, and that's an added burden, and it could affect their sleep. So there's all these different things to keep in mind. So yes, there are differences between men and women across all these conditions.
Yeah. And then the main reason that we do all these podcasts and discussions, whether it be with my patients or with practitioners or scientists, is to bring back hope to people. So if you have these conditions and it cannot be diagnosed or explained well with doctors, don't lose hope. That's the message. That because the science is expanding now, our understanding is expanding, and more solutions are coming. Because now we're talking about the common denominator of all of these, which is the stress, which brings us to the solution part that now working on how to manage the, first of all, recognizing the emotional trauma and the effect of the trauma on our nervous system, on our life experience, and then how to manage the stress, how it can help with the different types of modalities of therapies that we have, how that can change the level of stress that we perceive or the way we cope with the stress, and then hopefully as a result, different studies have shown that we can make a difference in the presentation of those different medical conditions that we talked about.
And we're living at a time that since 1990, mental health conditions have risen by up to 48%. It's increasing, and it's costing annually about $1 trillion in the world. It's expensive. A lot of people are affected by mental health at one point in their life, and it could be anxiety, depression, or one of these other conditions, or so it's about how do we, as a society, as a culture, encourage people living well, and also talk about prevention. So what you can do right now so you don't develop one of these conditions in the future. That's extremely important. So like public service announcements and PSAs, I would love to see commercials on, how to keep your mental health in check. Make sure you're exercising well, eating well, not being lonely. Like loneliness is also linked to depression.
Yeah.
And so there's so many things we can do right now as a society just to promote wellness. And
things like cognitive behavior therapy.
Yes.
You mentioned that in some of these conditions, There's a role for them of just managing the stress. And I remember in our last talk, you talked about even some of these practices can make actual changes in the
Yes.
in brain and neurophysiology of the brain.
Absolutely. And mindfulness meditation, there's different forms. We can even do a separate podcast just looking at meditation on its own for all the different types and how it affects the brain. And that's something you can do right now. There's so many apps, free meditations you can do just daily and commit to it. And I think a lot of the times where most people might be struggling is starting or feeling like, oh, they can't do it, or they'll do it tomorrow, right? Or how do they start now, right? They're so ingrained in their habits, right? Their habits of not doing the right thing. So how to break that bad habit and live a healthier lifestyle with all these great tips and tools that you talk about as well, especially in your practice. So I'm sure you see patients and have cases where, you provide these suggestions and they might not take it. And so how do you break that habit? How do they start, maybe even doing micro habits on how to incorporate these suggestions into their daily life? That's important.
There are different steps on my method that I use for my treatments with my patients. First of all, it's to tell them that what you are doing is what the condition that you have is real. Like we validate their condition, their suffering is real, and it's not we tell them, oh, your condition is in your brain. Of course, it's with brain that we perceive everything, but telling them that your pain is real, but the source of it is from your stress. The source of it is from your emotional trauma. First of all. And the second, we always start with the purpose, the reason why you want to get better. Each person's life has some important points that when you bring that point in front of their eyes, then they get motivated to bring all their life energy to the focus of doing something about it. And then they start to learn how to know their condition, make peace with their condition, and make peace with themselves, accept their condition, and then commit to the next step, which is learning the skills. So by first of all validating the condition that, okay, what you say is true. We may not be able to explain it with the conventional explanation that we have, but your suffering is true. And then we focus on why you want to get better. So they get some hope, and then they find the energy of focusing on the condition. Then we will talk about different skills that they can learn on how to manage the condition. We will definitely have another session talking about mindfulness and meditation and different solutions that we can have, because I know that there are different parts of the brain that will even grow if we do those practices. I'm sure you're going to explain all of that for us. Thank you so much, Doctor, for your explanation, and hopefully we can bring more hope and more solution to our patients.
Oh, it was a pleasure being here. Always happy to come.
Thank you, Doctor.
You.